But again, COVID is a little different. And typically, pleural effusions are able to be seen in both, but in ARDS, they're typically small, whereas since this is a high-pressure pulmonary edema, pleural effusions are more likely to develop. I want to quickly spend some time on talking about consolidations in a little more detail. And you can see here, oops, this is, it doesn't play, okay. So this is a classic lung consolidation that's really big. You see a lot of effusion fluid around it. You see the diaphragm right here. You can see the liver. And you see the lung. And the lung really looks very much like the liver. We call it hepatization. It's hypoechoic. It's gray like the liver. And it has air fluid bronchograms. These are quite important later on to diagnose things like pneumonia or aspirations, where you see here these black streaks are fluid-filled bronchograms, whereas if you have these white streaks or white dots, these are very likely mucus air bubble mixtures that are in the small airways. How does this happen? Basically, the alveoli represented here are being filled with fluid and cellular debris. And by that, all of a sudden, ultrasound is not reflected completely at the pleura, but is able to kind of depict by traveling through the solid tissue or fluid and show the lung as a solid organ. It is not clear just by looking at a consolidation what caused it, what's behind it. There are more signs that you can look for, but it probably would go beyond this webinar. I want to highlight that consolidations can come in all different shapes, and they can be large or small. And these are small lesions. This is anywhere from 0.5 centimeters to 2 centimeters. This is what we've seen most of the time in ARDS. These are small at the pleural line, small layers of fluid, anechoic layers, and then these dark areas, small areas that have sort of shredded lung at the border with a lot of comet tails coming off, and small heterogeneous white spots, white streaks, again, air bronchograms, fluid bronchograms in the middle. Here, this is a PE in the periphery. It has a very distinct shape. It's wedge-shaped. It's 1 to 3 centimeters, sometimes has a white dot. Or if it's very homogeneous, not irregular like this, it's more likely to be a tumor. But what we've seen many times in ARDS is this middle picture. And I want to highlight this here. And you can see here all these little indentations at the pleural line. Here it's even interrupted. So these are all signs very specifically for an inflammatory infectious process in the lung that's causing the pathology. In this patient, because we were worried about pulmonary hemorrhage, that's what I would have expected if there was significant pulmonary hemorrhage. This is a large consolidation right here. So just to orient you, here's the diaphragm. This is the liver. And again, you see the texture between the liver and the consolidated lung is very similar. And here you see like the small bronchi that I visualize. And you can see these white streaks that with insufflation, they get broader. This is basically a sign that this has been an occlusive process. And you can see some fluid bronchograms, these black streaks on top of it, that there's been either an aspiration or mucus plug that's causing the collapse and consolidation of the lung. And this would be something that I would be looking for if I think about intrapulmonary hemorrhage. What I want to highlight is that all the signs that we've talked about lung pathology are basically a continuum of worsening pathology. So you start with a normal lung with A lines. The moment you have B lines, you know that there's worsening lung density pathology, and it evolves to ground glass opacities, which are these confluent B lines, and end up ultimately in the lung collapse and consolidation. What's important to highlight, though, is if you treat these patients, you do regular exams, you can use this as well to kind of get a glimpse of improvement. Because if you had consolidation beforehand, now you have confluent B lines. This is a sign of improved aeration of the lung. So it goes both ways. It gives you an idea if you do repeated exam if the patient's worsening, but it also gives you an idea if the patient's improving. And we use this quite a bit during during the COVID crisis. So going back to the questions that we asked ourselves initially is like, what's the reason for this patient's worsening respiratory mechanics and oxygenation, worsening pressors? And one question was this worsening ARDS. Certainly there are signs of ubiquitous and severe ARDS in this patient, but it didn't look that different from what's before. So it was hard for us to say if this was really the reason for the underlying process. Then we had the question of the pulmonary hemorrhage. We said unlikely because that's why I highlighted consolidation process, because we did not find these solid consolidations with as an evidence of plugged mucus plug, blood clot plugging of the smaller airways. And so I thought it was rather unlikely that this was a large bleed. We later on did a bronchoscopy and confirmed that there was not a lot of bleeding inside the lung. The other question was large effusion and hemothorax, and you saw, especially with the exams that I did on the side, there was no large effusions, no indication of a hemothorax, so we could rule that out. And the pneumothorax was a worry that this was worse and caused the decrease in venous return and high peak airway pressures. But we've seen lung sliding very well in all sectors. Even though it was reduced, it was present. So we effectively ruled that out. So lung ultrasound in this patient already helped us narrow down quite a bit of differential diagnoses. This is just to highlight again how to diagnose a pneumothorax, but Penn mentioned a lot about it, so I'm just gonna skip over this. This is a lung point for a partial pneumothorax. We've seen that a lot. Most of our pneumothoraces in these patients been partial pneumothoraces. And I just want to highlight, this is just because it's I think the picture highlights this very well. You can see at the pleural line highlighted by the blue arrows, you can see the expanded lung. You can see by the moving pleura, but you can see that both sides look very, very similar because both of them have A lines. They have a pleural line, they have A lines. This is a rib with the shadow. So the only real difference is the moving pleura on the side of the partially collapsed lung and the absence of sliding on the air side of the pneumothorax. And this is the so-called lung point. You can see that the pleural line also is somewhat thicker and brighter when you have both sheath, the pleural and the visceral and parietal sheath rubbing against each other. Where in here, where you only have the parietal sheath, it's thinner and less bright. And this is how to imagine the lung point appearing. So I want to switch, and I highlighted this earlier, I want to quickly switch to a cardiac exam that I always do, and I teach that as a necessary step to really assess the pulmonary cardiovascular system well. I don't think it's wise to just stop at the lung ultrasound alone. It's always recommended to add at least a few views to see what's going on, because the lung and the heart, as we all know, are very closely intertwined in how they respond to disease. And here I always start with a subcostal four-chamber view. In these patients, high PEEP, high airway pressures, the lung is overblown. You have a hard time for those who do echo a lot. You have a hard time to see anything in the parasternal or in the apical views. So the subcostal view is really a great access for these patients. And you can see here, this is the right heart. This is the liver on top, the right heart, the right atrium, the left atrium, the left heart. You can see, just even if you don't do routinely echo, this seems to be squeezing quite well. What we like to look at is at the tricuspid annular ring right here between the atrium and the ventricle. And if it moves up and down really well, that is an indicator of a good RV function. You can see right there, there's good movement along that area. So there's pretty good biventricular movement in this patient. I always like to look at the IVC, which is now a longitudinal cut in the same area where we got the four-chamber, subcostal four-chamber. And you can see here, the IVC looks pretty plump. It's typically about 1 to 1.5 centimeters. This here looks like almost 2.5 centimeters. There's still some oscillation. We like to use the M mode with it. And you can see these waves that go along the IVC wall. These are the cardiac oscillations going from diastole to systole. as long as you see these waves in my mind, you know that at least the preload conditions for the right heart are still within a normal range. But the width of this suggests that there's a lot of preload or sufficient preload to the right heart. So hemorrhagic shock, bleeding, massive bleeding becomes very unlikely. Another view from here is just by using the same plane that we use for the IVC. So the ultrasound plane is going from head to toe, and I'm just swinging it, I'm tilting it over to the heart, and I get all the short axis view that I'm used from the parasternal short axis and long axis. And you can see here, this is the RV, this is the diaphragm, this is the liver, and my ultrasound beam is right there in the epigastric area. I scan through the liver, and that's why I see the heart really well. You can see at the periphery here that all these rocket tails, lung rockets, suggestive of this ARDS. But you can see the RV is small, the LV is small, it's contracting really well. And we've seen also a short axis view at the aortic valve level into the PA. In these patients with the high PEEP, high airway pressures, RV failure is always a concern. This is way too advanced, but I'm just showing it because we did it. We used Col Doppler to see where the flow is, and we looked at what the stroke volume is of the RV. And you can see here the stroke volume signal. This downtown, it's nice and broad, and it has a good velocity. So very suggestive. You could do this more detailed, but it would go beyond this, of a good RV stroke volume. And I think these patients are important because of the hypercoagulability to quickly look or make an effort to look at the femoral vessels to look for DVTs. And again, there are no DVTs. This was clear here in the veins underneath the artery. We expanded this because of the abdominal X-ray, and this is just an incident finding, but that I found very interesting. You see here small bowel loops on the right lower image here. You see two. One that's clearly moving has good peristalsis. For a small bowel, actually quite a bit of peristalsis. And you can see another piece of small bowel that actually looks thickened and does not move at all. So it kind of did not, that is suggestive or raises the suspicion for like a pathological process like ischemia. And with these patients being so hypercoagulable, we decided to do a CTA of the mesenteric arteries to rule that out. And here you can see the bladder with the Foley balloon in the right position, which is a thing I do when I do scan the ultrasound. And so back to the questions that we had initially for the worsening pressure requirements and hypoxia, septic shock. It is possible. The heart is working very well. It's a little bit on the hyperdynamic side. There are no other big explanations for why the blood pressure was dropped. So a septic shock, it kind of fits the picture. There is, excuse me, RV failure and strain. That seems unlikely. I have a small RV, I have good RV stroke volume, I have good function. Yes, the IVC is a little plump, but there's still the cardiac oscillations in there. It makes a florid RV failure as a reason for the hypotension very unlikely. And hemorrhagic shock as well, because of we ruled out the free fluid in the belly and in the case. So the second case, very similar, 52-year-old gentleman, 32 days with COVID, was improving, but then had increasing vasopressor support and a worsening oxygenation. And you can see here worsening anemia, renal failure, a classic in these patients, lactate increasing, suggested for poorer perfusion, leukocytosis and increasing procal, and marginal oxygenation and ventilation. Cooler extremities on exam. You see that here the infiltrates are less pronounced than on the prior patient, but still has quite a bit of ventilator requirements. ET tube was okay. Our key questions were, is there a pneumothorax? Because the high sudden increase in airway pressures, septic shock, hypovolemia bleeding, as these patients are severely coagulopathic and can go both ways, or worsening RV failure as part of the shock and hypoxemia. I bundled all the findings for the right lung. You can see here we have a positive spine sign in this area and a little consolidation with a small amount of fluid, a classic finding for us. You can see again the interruptions, the fragmented pleura, the small peripheral infiltrates up here. Also, thick line, tons of B lines, so classic for ARDS. And you can see that the chest X-ray really is, if you compare the two